All right, everyone, welcome to Neurology Grand Rounds. A little cold out there. Has this winter been horrible, or is it just I'm older? Yeah, it's been cold and wet and hot. No, it's just regular. This is today's CME code. Today's CME code. Kidney disease. Okay, so I don't know why this isn't showing up, but I will tell you what would be up here. Oh, wow, it does this? I did not do this, but I like it. Okay, so today's Ash Wednesday for the Catholics in our department, including myself. It's the start of Lent. It's also the Lunar New Year. Last time I did this, I mistakenly called it Chinese New Year. Year of the Dragon. And it's Valentine's Day today, so just FYI for everybody. Valentine's Day today. It's Valentine's Day. February is Black History Month. There are a whole bunch of events at Duke and Ask Rio or Rio. Where'd you get all this? Is there a website? Oh, scan that QR code. Get your cameras out. We have a lot of all-stars today, which is fitting, given that our department is phenomenal. So first, there's Roshni Doot and Natalia Dupree. Went above and beyond to care for a suicidal patient in the neurology resident. That wasn't when I was there. No one ever told me. That wouldn't have been surprising either. Nominated by Kyle. Thanks. Wayne and Shakar nominated. I mean, this Andrea, she's always getting. How many coffee cups do you have ever just for your all-star coffee cups? An unexpected stroke on the weekend. She came flying in. Do you have like a Superman cape on when this kind of thing happens? Congratulations. Kind of thing. Maybe Kyle got a coffee cup, but no, he didn't. He was in a some kind of media event with Warren Grill and Dennis Turner, Neuro News International, discussing more elegant DBS approach. Good news, Kyle. Might want to get another headshot. That looks like your college photograph. The research, Deborah Rose and Andy Liu, were in a paper called, something called Hellion, that investigated novel biomarkers in pregnant women and their possible risk for Alzheimer's disease. I love this one. Does everyone know what misophonia is? We don't have a case today, so I can take it. So misophonia, I had an assistant when I was at misophonia. Before anyone knew what it was, whenever I would chew gum, she would literally just lift off of her chair and go running, screaming. And we didn't know what it was. And then there was an article in the New York Times. She said, "This is it. This is it. This is what I have." And so she had misophonia for gum chewing. And I had two giant bags of blow pops in my in my office. We still had a very good relationship. We're still friends. But apparently Noreen was in the middle of stimulating someone and caused misophonia, which is my own misophonia for people who sit next to you and they got a little nasal drip and they're doing like, oh my God. Everyone has a little bit of misophonia. Wayne was the first author of a paper in Lancet, Regional Health Europe. There's so many journals. On transcranial direct current stimulation stroke rehab. Oh, and Suma, nicotine and tobacco research. Is that a tobacco company? smoking on patients in multiple sclerosis. So I'm sure it's not a good thing. But interestingly, my understanding is the only thing smoking is good for is not getting Parkinson's. I think I'm right about it. It's the only disease for which smoking makes you less likely to get it. Else? Ulcerative colitis. Nice. I didn't know about that. Great. Okay, so long, Dolly. On this day, February 14th, is February 14th always Valentine's Day? They put Dolly down on Valentine's Day, but this was in England. Do they have Valentine's Day in any other countries? Oh, it's spreading. I thought you said it was Friday. Does everyone know who Dolly was? Dolly was the first. Dolly. So Dolly was a cloned animal. 6 years, I think, and died of some horrible lung disease. We didn't know that when it was born. But yeah, Dolly was a big deal at its time. Not as big a deal as someone else we celebrated at Grand Mouse. Was the first in vitro person who was also English, had a baby of her own. Dolly's deal. So again, this is today's CME code. Get John. There's no case today. So our speaker is Maggie Soltis. I wanted to thank her for her flexibility. I bumped her around quite a bit. I'm excited about it. Thank you for that. So undergraduate degree at Elon, MD at Marshall, residency and fellowship here at Duke. And we've been thrilled to have her. She was a great addition to the department and to the faculty, including both in the sleep group and at the VA. She's going to talk about sleep medicine pearls for the neurologist. Will the weighted blanket be part of? For those of you who don't know, I did a little survey of how many people gets to sleep, and there were at least 5, probably 5+ people in this weighted blankets. And now that we had this huge inward migration over here, I bet the number is at least 10. I use one myself, and it's both a aid to sleep and a little bit of exercise in the middle of the night, getting out from under that thing. Mine weighs 20 pounds. As I get agitated and demented, I think I'll order the 40-pound variety. All right, Maggie, take it away. Thank you very much. Although when I get agitated and angry and demented, all you have to do is give me chocolate chip ice cream and I will calm down.
Yeah. Should I restart screen sharing? Okay. See? Okay. So when I was thinking about what to talk about for grand rounds, and also I will say I was very happy to be flexible in moving my grand rounds talk because it just was getting delayed. So I had more time that I could work on this, which doesn't really help when you procrastinate like I do, but that's okay. So I was actually reflecting on a really great talk that I think Jordan Mayberry gave as the chief resident, where he kind of just went through updated guidelines for stroke management. And I was like, man, that would be helpful to just like kind of get a refresher for everybody on something that I'm passionate about. Like if anyone wants to do this for any specialty, I would love to hear it. So I wanted to just go through and talk about updated guidelines and treatment of various sleep disorders that hopefully people can integrate into their practice to help their patients too. I have a whole slide about why I gave this talk. So I've also had a lot of fun being a part of the Duke Educators Academy in Neurology, which is just a bunch of us who are passionate about education. And one of the things that we started doing is trying to make kind of like a high yield cheat sheet on topics So like we have some within sleep, and I kind of just aggregated them together to make this talk. But that was one of my big motivations. I feel like in training, there's a lot of limitation to getting sleep medicine exposure. It's really just an elective, but like as we all know, sleep is so important in everything that we do and how we feel every day. So talking about sleep is super important. Management guidelines keep changing, and so that's huge. And I see patients coming in all the time who are on medications that they probably shouldn't be for various conditions. And so just kind of talking through when we use certain medications and why is helpful. And then I just like helping patients with sleep, and I like teaching. I have a lot of silly like comics throughout this talk. Maybe we'll have time to look at all of them. It's actually pretty lucky we didn't have a case presentation because this could get a little bit wordy. So I'm going to go through kind of some of the biggest topics within sleep. We're going to talk about sleep-related movement disorders, parasomnias, breathing disorders, and just ordering sleep studies in general, and like clinically when and why you should order them. Insomnia with just a touch of circadian rhythm disorders, and then also the central disorders of hypersomnolence. So first, let's talk about RLS. I ask my patients if they meet this criteria pretty much every time that I see them, because we get so many referrals for legs doing things or hurting that don't end up being RLS and are something unrelated. So what are the actual diagnostic criteria for this condition? So you have to have an urge to move the legs, and it can be uncomfortable, it can be unpleasant. Some people say it's painful, but generally speaking, I'd lean more away from the painful and more just something uncomfortable or unpleasant's going on, you move the legs. And then number 3, the movement makes it better temporarily, which is also important. This tends to begin or worsen during periods of rest or inactivity. So asking about that is important. And then is it worse in the evening or night than it is during the day? And so I get like a lot of consults for like neuropathy, where it's like there all the time, and that kind of, helps exclude some of that. Although I put my little asterisks at the bottom that augmentation, which I have a whole slide on, can change the manifestation. So long story short, augmentation occurs whenever people are put on a dopamine agonist and they start to develop worsening of symptoms that can occur during the day. So if somebody comes in with horrible augmentation, they might have symptoms all day, every day, and they're miserable. So it doesn't always have to be at night, but if you can kind of get a history and go back to before they started the medication, it should have been more of a problem at night or whenever resting or laying down. Another common question and things that we come across are restless leg syndrome and periodic limb movements of sleep the same? No, they can definitely run together, but they are 2 distinct conditions. So periodic limb movements of sleep are diagnosed by a sleep study, specifically polysomnography. Like you really need to have leads on the legs to know what's going on. So most home sleep studies wouldn't give you any idea of what's going on with the patient's legs at night. And if they move their legs 15 times an hour or more, well, more than 15 times an hour, then it would be consistent with the diagnosis of periodic limb movements of sleep. Patients are generally not aware this is going on. Their bed partner might be. Or I've had a few patients now who know that this is happening because they've actually like worn holes in their sheets, which is pretty impressive. The behaviors tend to be repetitive and highly stereotyped, kind of like quick jerking movements. Sometimes we're having to distinguish this from other sleep disorders like REM behavior disorder or parasomnias of some sort, but it tends to be pretty different. And when are periodic limb movements of sleep a disorder? When does it become periodic limb movement disorder? That's whenever it actually causes clinical sleep disturbance or daytime impairment. So like it has to be a problem for it to be a disorder, which makes sense and is true of a lot of conditions. And so I said, let's not start a benzo for asymptomatic periodic limb movements of sleep. And yeah, I see it, unfortunately, where patients come in, they're on Klonopin, they've been on it for 5 years. Somebody started it because they saw these movements on a sleep study. They didn't bother the patient. They didn't know they were happening. And at that point, I would argue you might be doing a little bit more harm than good. So if you have somebody with periodic limb movements of sleep noted on a sleep study and they're asymptomatic, probably don't do anything until they've come to see us so that we can actually try to tease out if there's something more going on or something simple. And kind of talking about that association with restless legs, again, is that feeling before you're falling asleep. It can happen at night too, where you know that you need to move your legs, you move them, they get better. periodic limb movements of sleep doesn't typically have that, but they do occur together frequently, and 5+ periodic limb movements of sleep per hour occur in 80 to 90% of patients with RLS. So they often go hand in hand. And if you see periodic limb movements on a sleep study, it does indicate they might have RLS, and you need to talk to them about that and treat it appropriately. So what are some triggers and what are some things to know? I absolutely love this card that's on the right-hand side of the screen. So this card is a medical alert card for RLS. It was kind of created and is offered by the RLS Foundation. And I encourage a lot of my patients that have RLS to think about getting it and sharing it with their doctors, because there are a lot of medicines. Like, it's obviously not like myasthenia, but I almost think of it in the sense that, like, I wish we had a flag in the chart. Please don't give these patients these medications, because you're going to drive them up a wall with their RLS. RLS is miserable. It's incredibly uncomfortable. And so if I can help my patients be an advocate for themselves by giving them access to this information, I think it can be really helpful. But some of the medications that are notorious for causing or worsening RLS, really worsening it, would be like the anti-nausea medications. And you can't really see it, but what I like about the medical alert card too is it says what to avoid, but it also lists what are safe alternatives to use for these patients. So we're not saying you can't use anything for like you can't give any anti-nausea meds, but you should try and use these ones because they tend to be safer, like Kytril, scopolamine, things like that. Antipsychotics, atypical neuroleptics, antidepressants are pretty notorious for causing this. Antihistamines, please don't give people Benadryl for sleep. I feel like I spend a lot of time educating patients on why that is never a good choice. Anything ending in PM is probably not a good choice for sleep, but we will talk a little bit more about insomnia in a bit. And then the dopamine agonists. These have been like the mainstay of treatment for RLS for a long time, ropinirole, pramipexole, but once patients start needing more of the dose and escalating the dose, they can become a real problem. And the only solution for augmentation is getting these patients off of the dopamine agonist, which is oftentimes the last thing they want to hear or even think about. So here we go. Actually, one more slide, and then we'll get to the augmentation part. So there was an updated algorithm by Silber et al. In 2021. It's a really, really good article that I highly recommend looking at if you're ever trying to manage somebody with restless legs. But what are the things that you should do when you're actually seeing somebody with RLS or periodic limb movement disorder? So first, you want to check their iron studies, ideally fasting studies, and you want to make sure that their ferritin's greater than 75 or their transferrin saturation's greater than 20%. One or the other, doesn't have to be both. If either one is low, you want to consider supplementation. Supplementation would be oral iron, 65 milligrams, elemental iron, or just 325 milligrams of like ferrous sulfate we'll often recommend. Taken with vitamin C for absorption. It can be taken daily, but it's just as effective if taken every other day. And so we often start with oral supplementation, give them a few months, like 3 months or so, recheck, see if we're trending in the right direction. And then if we're not, we might be talking more about iron infusions. Iron infusions are great. You have to be careful. You don't want to give somebody an iron infusion if their transferrin saturation is 45% or greater. But you can also get iron infusions covered if the iron can't be absorbed or is not tolerated due to GI side effects. So we often will document that. Then you're generally able to get the iron covered for them. There's this nice, this document's actually from that article I was talking about. It just goes through like general considerations, what's recommended for intermittent RLS, chronic persistent versus refractory. So it really does break it down nicely. But first line now is going to be an alpha-2 delta calcium channel ligand, like gabapentin, Lyrica, or Horizont. Horizont is a slightly different formulation of gabapentin, which is thought to be more bioavailable. You don't need the doses to be as high. But of course, because they went and got that indication for it, and for RLS, it's very expensive and hard to get. So we generally start with gabapentin or Lyrica. I like them because they can help with sleep. And we'll talk about gabapentin more in a little bit later. And they don't worsen your restless legs, which is the biggest concern with these dopamine agonists. So second line would be a consideration of a dopamine agonist. Third, you're starting to think about opioid monotherapy. That's when I would say, definitely think about sending them to the sleep clinic. There are some other really like new, interesting options that can be tried. And you can send all of your RLS patients to Dr. Spector. because he's really good at managing RLS and seems to really like it. Not necessarily my cup of tea, but RLS is very rewarding because you can really make a big difference in people's quality of life with it, just with some simple interventions. Yeah. So Cinemet's interesting. Cinemet can be a very helpful medication in RLS, but only if used in extremely like brief settings. Yeah. Yeah, more often than not, we would probably try a dopamine agonist, like one of the like ropinirole or pramipexole, but Cinemet would kind of fall in that same category and line of thinking where they are pretty specific for RLS. And like, because gabapentin, obviously that helps with a lot of different types of pain and discomfort and nerve pain. So it's not as specific for RLS, but yeah, definitely using something that's dopaminergic can help you tease it out. So yeah, it's not a bad idea, but with Cinemet in general, big thing is just not to put people on it long term because that's really bad for augmentation. But we use it sometimes as like a rescue for like a flight or something like that can make a big difference for people. So augmentation, it is the bane of my existence. I don't know if I can speak for everyone in the sleep clinic. But we get these referrals for severe refractory restless legs, and then this patient's on 6 milligrams of ropinirole, and you're like, oh my God, what's happening? And then they're like, oh, well, I talked to my neurologist or my doctor, and they said that we use, really high doses in Parkinson's. So we just kept going up. And then they have this horrible augmentation process that's begun. What is the mechanism of augmentation? It's unclear, but it's thought to be due to excess postsynaptic desensitization of D2 receptors in the substantia nigra and putamen with this chronic intermittent dopaminergic stimulation. So over time, you basically just need more of the medication and at higher doses, and sometimes dose more frequently to control symptoms. So somebody will be started on a dopamine agonist, they feel great, everything's so good, and then in a couple of months, they start noticing their symptoms are coming back. Maybe they're a little bit worse. Maybe they're starting to be in a different part of their body, like their arms, maybe happening earlier in the day. And so they go talk to their doctor and they're like, sure, let's just go up on the ropinirole. And then this becomes a vicious cycle where it's just happening over and over. And you get to this point where you're needing massive doses of a dopamine agonist to get a little bit of relief. And then they end up coming to us and we have to explain to them that we have to come off of the dopamine agonist, which is never fun or easy. The dosages used in RLS and recommended for RLS, as you can see, are not very high. I actually thought like pramipexole up to like 0.75 milligrams was reasonable, but even the updated guidelines are saying lower than that is better. Sometimes we use the rotigotine patch when people have augmentation, like it's a little bit less prone, but in general, you just have to get them off the dopamine agonist and transition to something like gabapentin, maybe an opiate, especially in that kind of immediate period if they're not doing well. Generally, I try to be nice and wean slowly to avoid dopamine agonist withdrawal syndrome. I recently had a guy who was on dopamine. He was one actually who had this amazing neurologist across the country who had him on really high doses of dopamine agonist. And then he was really upset when I wanted to wean him off. And so we tried to wean him off gradually. I put him on an opiate in the meantime, and he had just like crazy panic attacks that he'd never had in his life. And I think it actually may have been a manifestation of this dopamine agonist withdrawal syndrome because I couldn't find any association of what he was experiencing with the opiate, but that's what in his mind was happening. So that was a pretty challenging case, but people can feel really awful and sick and anxious and all sorts of things whenever they're coming off of a dopamine agonist. So we try to do it gradually, carefully, and gently. But yeah, if you're ever like wondering, how do I even diagnose augmentation? Those are just kind of some of the questions I briefly mentioned that you would look for or think about asking that can help you tease out if augmentation is actually happening or like maybe their RLS is actually getting worse for some reason. So that's RLS. So parasomnias, these are one of my favorite disorders within sleep. What are they? They are undesirable physical events or experiences that occur during entry into sleep, within sleep, or during arousal from sleep. This comic's kind of funny. I actually had a patient who had some sort of like hip surgery, and she had an episode where she got up in bed and like stood up on the bed. She hit her head. And what was interesting is and it was post-surgical, like she shouldn't have even been moving, but she was able to do that. And she even told me, she was like, I don't even think I could do that if I wanted to, if I was like awake. she had a lot of weird parasomnias, but so even, breaking someone's leg might not be enough to get them to stop doing it, but that is not my parasomnia treatment algorithm, but just kind of a funny comic that I found. So when it comes to parasomnias, we always have to try to tease out, is it a non-REM parasomnia or is it a REM parasomnia? That's important because they're treated very differently, and the treatment for one, like non-REM parasomnias, could actually worsen another one, a REM parasomnia. So you have to try to tease out which is which. One of the best ways to do it is to think about the hypnogram, the sleep architecture, and when it would make more sense to have one type of parasomnia or the other. You can see in this nice little graph up here, you get most of your deep sleep and your non-REM sleep in the first half of the night, most of your REM sleep in the second half of the night. So that's one of the easiest ways to start, is to try to figure out, is this happening during REM sleep or, in the first half of the night, second half of the night, to figure out if it's non-REM first half of the night versus REM second half of the night. It's obviously not perfect because you can see you get REM even in the first half of the night, but it can help to try to figure out what the pattern might be there. The non-REM parasomnias are disorders of arousal. So confusional arousals, where people sit up, look confused, and then kind of go back to bed. Sleepwalking, I think we all kind of know what that is. Sleep terrors, where people are screaming, they look absolutely terrified, but have no awareness of what's going on. Very common in children, very distressing for parents. But again, the kid doesn't really know what's going on, and it's not really bothering them, that we can tell. And then also sexsomnia or sleep sex. I bring that one up just because I gave a case of, a couple of years back about that. Here is a more rare type of non-REM parasomnia that we can see. And then sleep-related eating disorder, where people have repeated episodes of dysfunctional eating. I had a patient wake up with like aloe coming out of her mouth. Like, you can get people that eat some really weird stuff in their sleep. So what is the general treatment for non-REM parasomnias? This is definitely something that I think most neurologists could kind of triage and manage like in their clinic, because it's really reassurance for the most part. If you can explain to these patients that, as long as they're safe, as long as it's not really bothering them or their bed partner, it's probably going to be okay. There are things they can do to try to prevent it from happening, like avoiding sleep deprivation. Stress is a huge trigger, which, we know you can't really get rid of stress, but you can try to make changes in your life that might make it less stressful. Sleep studies are not always necessary, but sometimes they are helpful if you can find an underlying sleep disorder that's disrupting their sleep, which is then leading to the sleep deprivation, making the parasomnias worse. If you do need to start a medication, then antidepressants have been shown to be helpful. I try to consider those first if I can, just because I don't love putting people on benzos. But the antidepressants taken every night can help, or sometimes I'll use clonazepam. Like, I have some patients who sleepwalk, and they don't mind if they're in their home, they can lock their bed, they have ways to be safe. But if they're going for, like, one patient in particular, she loves to go on these like girls' weekend trips, and she's so embarrassed by her sleepwalking that she just takes clonazepam when she's on those trips, and then she doesn't have to sleepwalk, and it's okay. So there are definitely ways to help with the parasomnias that don't require medication to be taken nightly, but sometimes just talking to patients about it and understanding what's going on, and that they can, be safe and have parasomnias, and that, sometimes that's enough for them to feel reassured and not worry about it. A lot of people grow out of them too. I didn't mention that, but it's very common in kids, college years, that sort of thing. And then it does tend to get better for most people. So then REM parasomnias. This one had a very recent update to the treatment guidelines, so I think it's really important to talk about. What is REM behavior disorder? So these are repeated episodes of sleep-related vocalizations or complex motor behavior. Again, kind of like we talked about, more often in the second half of the night. If you did a sleep study and you captured an event of REM behavior disorder, you would expect to see REM sleep without atonia, meaning normally we should be paralyzed during dream sleep so that we can't act out our dreams and hurt ourselves. But in these patients, they lose that paralysis that they should have, which is what allows them to dive out of the bed and do all these things that ends up in injury. If you woke somebody up while they were having REM behavior disorder, they should be coherent, oriented, and can often tell you about the dream they were having, and it clearly correlates with the behavior they were demonstrating. If you ask them the next morning what happened, they might not know. So I think that's kind of confusing. Like, on boards and stuff, it's like they should remember their dreams, but in practice, if you actually ask them the morning after, and they weren't woken up, they might not know what was going on. So it's not like that clear cut that they're always going to remember their dreams. Injuries are very common. And I think that's often when they seek care and when they end up in our clinic is once they've hurt themselves by acting out their dreams. And if they are sleepwalking, think about the diagnosis, because that's not common in REM behavior disorder. In REM behavior disorder, your eyes should be closed. And I think that makes a lot of sense because that's why people dive. That's why they hurt themselves. But it's normally kind of around the bed is where I would expect them to be or injure themselves. If they're like in another room in the house, then that's a little bit less suspicious for REM behavior disorder, more suspicious for a non-REM parasomnia. With sleepwalking, people tend to have eyes open but kind of like glazed appearance, but that's why they can navigate around without actually getting seriously injured. But the updated guidelines for treatment added 2 new medications, which I think is pretty interesting and exciting, because historically it's always been melatonin or clonazepam. Melatonin has always been my first line treatment option because it's generally pretty safe. It's generally pretty well tolerated. In terms of melatonin dosing in general, most people don't need high doses of melatonin ever, but REM behavior disorder would be like the one time where it's really makes sense to go higher. So up to 15 milligrams is recommended. That's immediate release. There's a lot of these like time release melatonins out on the market right now, but that's not what would be recommended in this case. Clonazepam 0.5 to 1 milligrams can be recommended for RBD and can help a lot. Pramipexole is one of the new additions, so one of our dopamine agonists, dosed at 0.125 to 0.75 milligrams. If you have a suspicion for REM behavior disorder and restless legs or periodic limb movements of sleep, this could be a good time to consider using Mirapex. And then rivastigmine, this is interesting. I still haven't actually used it for RBD yet, but doses 4.6 milligrams up to 13.3 milligrams could be ideal for patients with RBD and MCI and dementia. REM behavior disorder is often associated with neurodegenerative conditions, specifically the alpha-synucleinopathies, and you can have some memory issues with that. So I think being able to use rivastigmine for REM behavior disorder management is huge, because now instead of potentially worsening dementia or making memory issues worse with clonazepam, we actually can offer something that might help or make a difference in some way. So I was really excited whenever that became a new recommendation. And then when it comes to having the conversation with your patients about REM behavior disorder, if you have someone that you think really fits the bill for an isolated or idiopathic RBD, meaning, a guy, it could be male or female, but I normally think of like my men in their 60s to 70s who have been acting out their dreams. It's been progressively getting worse, and they don't have any other like huge comorbidities like screaming you in the face that could explain that they would have RBD for another reason, like severe untreated apnea, narcolepsy, PTSD. Then the conversion rate from idiopathic REM behavior disorder to a neurodegenerative syndrome, I can't talk, was 6.3% per year. Overall, I would say about 73% is what I tell patients, likelihood that they would go on to develop a neurodegenerative condition. And I don't say neurodegenerative, I should take that back. I normally just say neurological condition. I try to just kind of leave that conversation up to my patients, and if they want to go there. And this was actually related to, we had an RBD expert speak with our sleep group the one day, and he was saying how he likes to talk to patients about it is to say, I do think you have REM behavior disorder. It can be associated with other neurological conditions. That's something that you want to hear about or talk about. And then it kind of lets them decide if that's something that they want to broach or explore. Or I have had patients already say no. It's not common, but I did have one who was like, no, I'm good. I just, we'll treat it, we'll work it up, that sort of thing. But RBD is a clinical diagnosis. You don't have to have a sleep study showing REM sleep without atonia, but sometimes it's helpful. And sometimes we get the sleep study to rule out other sleep disorders that could be contributing, because if you have severe untreated sleep apnea, that can cause people to act out their dreams. So we do have to keep the differential a little bit broad. I have a friend whose sister, who's like 28, has REM behavior disorder, and she had a sleep specialist in another state tell her, in 10 years, you're probably going to have MS or Parkinson's. And I was like, interesting, probably a little inappropriate. Like, I think we need to do a little bit more, figuring out what's going on before just saying a blanket statement like that to somebody. So that's why I would have that conversation with caution and make sure that like you really think this person fits the bill specifically for idiopathic REM behavior disorder before just kind of saying something like that. Because I mean, she's a mom, she was terrified, and that's how I got involved after that one. Mhm. Yeah. I mean, there are a lot of different medications. Like I feel like melatonin, vivid dreams. And I just try to figure out with the patients, like how much does it bother you? Like with a cholinesterase inhibitor, if the dreams feel more vivid, but they're not acting them out, themselves to their bed partner, maybe that's a win. But it's really just like a conversation about is it helping or is it not, and what's going to work best for them. And I don't know if I said it, but with like these conditions too, making sure their bedroom is safe is like really important. That they don't have, their nightstand next to their bed that they're going to hit their head off. They don't have a gun next to their bed that they're going to grab in the middle of the night. Things like that are really important. But yeah, I don't know that I've had patients who say I don't want to take it because of the vivid dreams, and that's okay. It's their call, and there are other things that we can try that might help or be less likely to do that. Um, no, yeah, I feel like we see vivid dreams in a lot of conditions. You can see it in, I mean, even if you're just like really stressed, really tired, having disrupted sleep, a lot of different things can kind of provoke vivid dreams for people. See it a ton in narcolepsy, but of course we just see a lot of narcolepsy in this clinic. But yeah, some people dream a lot, some people don't dream a lot, some have really vivid dreams, some don't, and sometimes it plays a role, but yeah, it's not super specific for anything. So next we'll talk a little bit about sleep-related breathing disorders and sleep studies. I'm not going to go crazy talking about this one because I don't think for a lot of neurology it's like all that important. But I think it's important to talk about how to order sleep studies and when, because this is something that we do a lot. My first request of everybody is if you think somebody needs a sleep study, please order it. We get more and more referrals to the sleep clinic where they're coming to see us to order a sleep study, and then that means they've waited 8 months to see me, and they wait another 6 months for like a sleep study, and it's just a lot of delays in care happening as a result. I don't know for sure, but I think some of it may stem from, the whole authorization process, what will insurance pay for, doing peer-to-peers, things like that. When you go to order a sleep study, this actually pops up like on the left-hand side of the screen when you're ordering it, and it tells you which insurance companies are more likely to cover what. I do think it's starting to get maybe a little bit outdated. For example, like Blue Cross Blue Shield, I am not seeing them cover a lot of in-lab sleep studies. I'm having to fight with them more. But if you're ever unsure, like just get a home sleep study at least. I think it's a pretty good place to start. Insurance companies probably aren't going to fight you on that one. And it helps at least get some initial answers, like do you have sleep apnea? And even if it's negative, that doesn't mean you don't have sleep apnea. It could mean that you need an in-lab sleep study to really show that. But we'll talk a little bit about that. But yeah, this is just, I wanted to make sure people know this table exists. It's there to help guide you. But anytime that you think somebody needs a sleep study, if you can start the process of ordering it before putting in the sleep referral, it actually helps us a lot. So it's like one of those like where we just get so many pop-ups and windows that we just like block them out completely. But yeah, anytime you order, you can pick like sleep study, all these options on the left, and the whole left or on the right, and the whole left side of the screen is this big white box that shows what's covered and what's not. But it is a lot of words, it's busy, and I think it's just kind of a natural defense mechanism to just like not even see it or pay attention to it, but it is there. So I like to make sure that people know it exists. So when is which study appropriate? So the home sleep studies are a good screening tool for diagnosing sleep apnea. And it's likely to be helpful for those with a high pretest probability, somebody who is obese and snoring and having daytime sleepiness. A home sleep study is probably good enough. If you have a 20-year-old female with a BMI of 18, probably less likely to capture a diagnosis of sleep apnea, because when we do home sleep studies in general, we don't have EEG leads on the head, And one of the ways we can score respiratory events is if you have trouble breathing associated with a microarousal from sleep. But in most sleep studies, most home sleep studies, we can't even score those events because we have no idea if there are any microarousals from sleep. Insurance doesn't care like that's an appropriate indication for doing an in-lab sleep study. So no matter what, sometimes they just make you get the home sleep study as that initial screen. But then once a home sleep study is negative, they will generally cover the in-lab sleep study. So that's why I say, when in doubt, just start with the HST, and that at least like crosses one thing off the list that would allow us to get an in-lab sleep study if needed. The in-lab sleep studies add the EEG monitoring, they add the limb leads that can allow us to look for periodically movements of sleep and REM sleep without atonia. So parasomnias would be a good time to prioritize like getting a PSG over an HST. And you can also add CO2 monitoring, and that's really helpful for patients that you're worried might have an obesity hypoventilation syndrome, or something where we really need to see if they're getting like hypercarbic. So those would be the times where one might be more appropriate than the other. And then this is just kind of like my quick summary of how are we actually treating sleep apnea now, because a lot of people don't realize there are a lot of different options out there. So the most effective treatment is CPAP or PAP therapy in general, positive airway pressure. I really like it, and a lot of I feel like a lot of young people who like technology like the fact that you get daily feedback on how well your apnea is controlled, which is really nice because you can tell every day if things are working well. If they're not, I think that increases compliance because people see like a visible change in their numbers and that sort of thing, which is nice. An alternative to CPAP, and CPAP's good for mild, moderate to severe sleep apnea. It can, and PAP therapy in general, I should say, can be used to treat central sleep apnea too in certain circumstances. The two ways that you can treat central apnea are with a BiPAP ST machine where they can initiate breaths for you, or an ASV machine. There was a big trial, the SERVE-HF trial, that showed that an ASV machine is not appropriate for patients with an EF less than or equal to 45% because there was an increased association with all-cause mortality. So sometimes we have to think about that and get echoes on patients. But again, I don't know if that's really relative to a neurologist person, but sometimes is a consideration for us. This is an interesting point I just want to bring up, is that CPAP in the very elderly, meaning patients over 80 years old, there have been studies showing limited to no benefit. So we get a lot of referrals from the memory clinic and see patients that are like in their 80s with, say, moderate sleep apnea, and they hate it and they have dementia, and it's really confusing and disorienting for them to wake up with it on. And I have a really low threshold to tell them it's okay, don't worry about it, because we do have evidence saying that maybe it's actually not that helpful in 80-plus-year-old individuals. But it's a decision to make with every patient, because some patients that are 80 love their CPAP. So I'm not going to take it away from them if they love using it and they sleep better with it. But just know that although we think CPAP's great and helpful, that might not always be the case. For mild to moderate sleep apnea, mandibular advancement devices made by a dentist can be helpful, especially for patients that don't want to wear a mask on their face, don't always have electricity, say they like to camp a lot, things like that. You might suggest they work with their dentist on getting a device for that. One of the new exciting things that a lot of patients ask about is the hypoglossal nerve stimulator. Dr. Augustine pretty much runs that clinic now. This can be an option for patients with moderate to severe sleep apnea with an AHI of 15 to 65 times per hour, although that's kind of variable and insurance dependent. But basically, if somebody's having trouble breathing 15 to 65 times an hour, they would meet the criteria there as long as it's obstructive sleep apnea. They have to have tried and failed CPAP, and they have to be fairly thin, like a BMI less than 32 is generally what's covered by insurance. But this is a device that's implanted in the chest that stimulates tongue movement associated with breathing at night to try to open up the airway and prevent apnea. Is kind of like the basics of that one. It is a surgery, so it's not like a minor thing, even though the commercials make it look like it's real minor and you just have a little warm and your apnea is gone. But so it's kind of a big deal, but a lot of patients like to think about that and ask about that as a treatment option. And then we do have a sleep surgeon now at Duke. This is kind of new in the last year. Like, we've had ENTs that have an interest in sleep, but Dr. Comesso actually went and did a sleep surgery fellowship and came back after doing her residency here. So she's a great person to refer to if you think your patient would benefit from surgery to treat their sleep apnea. Okay, insomnia is a big one. We all see it. We all talk about it a lot. So I know it's something I really wanted to bring up and focus on a little bit. Whenever you see somebody with insomnia, I think a lot of us don't want to ask about it because it's a loaded question. It's a long conversation, and sometimes it can feel really challenging to treat. But it is important to talk about insomnia and try to figure out why it's happening, since that's what will guide management and really help these patients. So first you want to figure out, is this insomnia acute or chronic? It's chronic if it's been going on for at least 3 nights per week for greater than 3 months. Is it trouble falling asleep or staying asleep? That helps us determine, is this sleep onset insomnia? Is it sleep maintenance insomnia? Or is it both? Because it can't be both. You always want to screen for other disruptors of sleep, especially if it's trouble staying asleep more than trouble falling asleep, because it's not normal to wake up multiple times per night. And so if you're doing that, you want to figure out why. And so sometimes sleep studies can be helpful in that setting. There are some imposters for insomnia. I mean, it is in a way kind of insomnia, but people that have advanced sleep phase will fall asleep early, but that leads to early morning awakenings that can really bother them. So trying to get a sense of when they're going to bed and if that's in any way contributing to them waking up in the early morning. And then also delayed sleep phase would be the opposite. I think of like teenagers for this one, where they have a hard time falling asleep until 1 or 2 a.m. and then they sleep in later than most people because, they need their 8 hours of sleep. Advanced sleep phase would be more elderly patients who, have dinner at 4 p.m., going to bed at 7 p.m., but then they're waking up at 4 a.m. and they don't know why. So just kind of trying to get a little bit more sleep history can help you figure out if maybe it's a circadian rhythm disorder and not just kind of clear-cut insomnia. So how do we treat chronic insomnia? Acute insomnia is, I don't want to say easy to treat, but you want to treat acute insomnia aggressively with medications to try to stop that process before it becomes chronic insomnia. Because once you have chronic insomnia, that's kind of hard to treat. It takes a lot of work from the patient's end to try to kind of retrain the brain and body how to sleep. But the way to do that is with cognitive behavioral therapy for insomnia. And what is that? So patients hear that and they think it's talk therapy with a psychologist, but it is much, much more than that. CBTI is essentially sleep retraining. And I tell them it's almost like a boot camp where you have to retrain your body to go to bed, fall asleep, stay asleep, and wake up again. One of the ways to do that is to restrict time in bed. And at sometimes we're even just restricting sleep in general. So what you do is you say, maybe to start with, you're only allowed to even be in bed for 6 hours. And then once you can consistently get into bed, fall asleep, stay asleep for 6 hours, you can gradually increase the amount of time they're allowed to be in bed. So it's not fun. Like people that work, that sounds like their idea of, not good things. So it's really hard to talk patients into wanting to do it, but it's really the only thing that's going to kind of reset the cycle that they're in. There are other strategies that they use. Generally, it does work best if you're working with a sleep psychologist and you do this for 4 to 6 biweekly sessions. You can take sleep medications while you do this. That's another question I get from patients, is they're really scared to not have their Ambien or something. But they can be on sleep aids with the goal to ultimately wean them off. And it is much, much more than sleep hygiene. I think we put so much emphasis on sleep hygiene, but realistically, when you have chronic insomnia, you're kind of beyond that point. Having light blocking curtains or something is going to be the, savior that you need to get your sleep back on track. So how do we get this? What I generally do is I recommend a Dr. Danforth. She's in our community. She used to be here at Duke, but she's phenomenal. So if I can get my patients to work with her, they tend to have really good outcomes. But it's hard to find, a lot of patients that want to work with sleep psychology in general because it's expensive and insurance doesn't pay for it. So the estimated cost is about $1,200 for a whole treatment course of CBTI. And most people can't afford that, don't want to pay for that. So that can be really hard to get people, kind of open to that idea of, I'm going to make your life terrible and you're going to pay a lot of money for it. And then eventually, hopefully you'll get better. So it's a hard conversation to have, but some people do it and do really well. She does, pretty much everything by Zoom, I think, at this point. I don't know that she offers any in person. She might. But there are like online resources as well, and a lot of people who do this over Zoom that you can find just by like Googling CBTI online. There is a free app that's actually through the VA called CBTI Coach. It's not the most user friendly, but if you have somebody who's really motivated and doesn't have the money to do CBTI, it's a way they can kind of do it in a self-guided fashion. What's hard is just having that motivation to kind of make yourself suffer in a sense through that kind of sleep restriction part of it. Yeah. Well, and then you do get into conversations of like, is it a short sleeper? So some people, like I think Dr. Hussein might be a good example where they just don't sleep that much and they seem to do really well. There are some people like that. There are other things like paradoxical insomnia. So if they have insomnia, I mean, by definition, you have to have some sort of negative consequences from it to have insomnia. So if you have somebody that like feels great, like I've had a consult like that, like a patient who's like, yeah, everyone tells me I need to come in. I sleep 5 hours. I feel great. I don't do anything about that because, you know, it could just be that they are made that way. They're a short sleeper. You know, we say 7 to 8 hours to everybody, but realistically, everyone's on a bell-shaped curve and not everyone's going to perfectly need that amount of sleep. Some people need more, some people need less. And I think we kind of sometimes overgeneralize with these statements of how much sleep people need. If you sleep 9 hours, you're going to have dementia. If you sleep 7 hours, you're going to have dementia. Like, I think there has to be some flexibility, and it just depends on how much it bothers the patient. Another really like affordable option is like this book by Chris Winter. I know has helped a lot of patients. The Sleep Solution, and just kind of like learning how to think about insomnia and understand it in a way that like once you start embracing it in a sense and not fearing it so much, that can be enough to really help you overcome it. Like I know for me, if I have a night where I can't sleep, at least I know the next night I'm probably going to sleep pretty well. And even if you can just kind of like change your mentality a little bit, that can make a big difference for some people. But I do have a dot phrase that's just .cbti resources that anyone can steal that kind of lists like how to contact Dr. Danforth and all those other, you know, potential treatment options for patients with chronic insomnia. And then I always think it's important to talk about the actual pharmacological treatments that are recommended. Again, for chronic insomnia, this is not first line. For acute insomnia, this could be first line. These are outdated. They are from 2017, and I think that they could definitely use an update, but it is what it is. And the way that I like to think about this, I'm getting warned that we're starting to get close on time, is I almost think of it like seizure management, where there's some medications that are good for like focal seizures. There are some that are better for generalized seizures, and then there are some medications that are really good for both. And so what you want to do is break it down into sleep onset insomnia versus sleep maintenance insomnia, or do they have features of both to guide what treatment option might be right for them. So if they have a hard time falling asleep, Ramelteon or Rosarum, which is the melatonin receptor agonist, is one of the recommended medications to help. Sonata, which is a Leplon, so it's a Z drug, it's in the same family as Ambien, is a really interesting sleep aid because it has such a short half-life. So it can have really interesting indications for patients that only have trouble falling asleep, or I actually personally like it for patients that say wake up at 3 a.m., they have to get up for work at 6:30, they can't take a sleep aid at 3 a.m. because they don't want to be groggy all day. But Sonata actually might be a good fit because it's so short acting, it lets them get that little bit more sleep without having a lingering effect. Halcyon, I've never prescribed in my life. It's a very old benzo, and I personally would not recommend this for the treatment of sleep onset insomnia, but it is part of the guidelines and what's been recommended in the past. When it comes to sleep maintenance insomnia, Doxepin, great medication, tricyclic antidepressant, can work really well. Belsomra, I have a whole section coming up on Belsomra that I really want to get to, and the orexin receptor antagonists in a moment. But this is a newer medication, or this class is a little bit newer. And there's a lot of interesting evidence for it being beneficial in a few different settings. So we'll talk a little bit more about that, but that can be great for sleep maintenance insomnia. The newer ones are Dayvigo and Qubivic. And then what's good for both? So Lunesta or Zopiclone, also a Z drug in the Ambien family, but less side effects of parasomnias like we often see with Ambien. Lunesta helps with sleep onset insomnia, sleep maintenance insomnia. So if I'm ever not sure or just want to try something, like this would be my Keppra. I use Lunesta a lot. It helps a lot of people. Not as many side effects as Ambien, but still effective. And then I'm going to try to just kind of keep moving a little bit. So what does the AASM recommend against using? Benadryl, which we briefly talked about, anything containing diphenhydramine. Melatonin, lack of benefit. That one's interesting because we use melatonin a lot. A lot of people like melatonin. I'm not saying we use it a lot in the sleep clinic, but in general, inpatient, stuff like that. Tiagabine, not recommended. Valerian root, L-tryptophan, and trazodone. That's a big one because everyone's on trazodone for sleep. But trazodone has a lot of side effects, headache, somnolence, has a very long half-life, so it stays in the system a long time. And so it's actually recommended that we don't use it by the AASM. So it's just kind of interesting. So here's my like honorable mentions for the dual orexin receptor antagonists, like suvorexant, lemborexant, daridorexant, kind of that Belsomra family. Is there a role for this in memory disorders? So in April of 2023, there was a randomized controlled trial looking at CSF amyloid beta, tau, and phospho-tau levels after administration of placebo versus 10 milligrams versus 20 milligrams of suvorexant. Small number, 38 patients, cognitively unimpaired, but they did find that the highest dose decreased amyloid beta by 10 to 20% compared to placebo. What does this mean? We don't know. It's like a very small trial, but it's just kind of interesting in the sense that could there ever be a benefit of a sleep aid for memory, which would be really nice to know because so many of the sleep aids have been associated with an increased risk of dementia. So if we had anyone that could actually help in any way, that would be a big improvement. Migraine, there have been studies showing that these medications can actually decrease migraine severity and frequency. I was very curious from the headache specialist if anyone's actually seen any benefit with this clinically. I actually learned about this from one of our headache specialists, like citing an article in their note and saying they might consider using Belsomra next. And I was like, what? And so it's interesting that it could have some benefit there. And then I just added this slide yesterday in honor of Shri Shah, who was wanting to know what can be done for inpatient sleep medicine or ICU sleep. So there was an article showing that suvorexant can be helpful in the prevention of delirium during acute hospitalization. This was actually a systematic review. They ultimately narrowed it down to about 6 studies, I believe, that showed that 15 to 20 milligrams of suvorexant appears to be a safe and effective treatment option to decrease delirium, time to delirium onset, reduce hospital length of stay, and improve sleep quality. So that's interesting. And it's worth noting that we are actually going to be doing a study here looking at suvorexant and postoperative delirium. So we're going to continue to explore that. More research needs to be done, but kind of interesting and could be helpful. When it comes to using melatonin, like in the hospital, if we're going to use it, can we at least just schedule it like a few hours before our goal bedtime? When I'm in the hospital, I see a lot of patients who get melatonin at like 2 a.m. because it's a PRN and that's just when they decided to say they couldn't sleep. But I think if we're going to use it, at least scheduling it could make a big difference. And then, of course, delirium precautions. Like not only are they for delirium, but they help you sleep if you're getting light exposure during the day and things like that. So those were some of my tips for inpatient sleep. My honorable mentions, these are just some medications that are not recommended by the AASM, but that I use a lot. Gabapentin enhances slow wave sleep in patients with primary insomnia. So it's one of the few medications that actually improve sleep quality. And when you explain that to people, they're like, oh, interesting. Yeah, I want to try that. And then I think even just having them kind of like buy in and have hope that this is going to help honestly leads to better outcomes. So I use it a lot. It's also used to treat restless legs and periodic limb movements of sleep. So it can like kind of kill 2 birds with 1 stone, so to speak. And so I use that one a lot in clinic. Seroquel can have a bit of an anxiolytic effect, which is nice if we feel that anxiety is a big component. Mirtazapine increases slow wave sleep and can also be used to treat paradoxical insomnia. So I see a lot of benefit with that. And then magnesium is something that just keeps gaining popularity in social media. There has been a study showing benefit. This was in the elderly. So when patients ask me about it, should I take it, should I not? I think in general, it probably has some potential for good, not a lot of potential for harm. So I don't tell them that they can't take it or shouldn't take it. If they want to try it, they can. but they might want to use a glycinate or threonate version, which would have less laxative effect. GI side effects tend to be one of the bigger issues with taking magnesium. And then in general, I'll try to do this quickly. Narcolepsy versus idiopathic hypersomnia are two primary central disorders of hypersomnolence. Narcolepsy has more of the positive symptoms, so vivid dreams, like we kind of talked about, sleep paralysis, hallucinations. Cataplexy, which is kind of sudden onset muscle weakness, can be fairly focal, triggered by emotions, and parasomnias. Patients with narcolepsy tend to have naps that they find refreshing that are fairly short, like 20 minutes, and they tend to have very disrupted nighttime sleep, which is very different phenotypically from idiopathic hypersomnia, which is the other primary central disorder of hypersomnolence. And I just think of those patients as sleepy all the time, no matter what. I have a dot phrase, that dot narcolepsy HPI, that if you're ever seeing a patient in clinic that you're worried has a central disorder of hypersomnolence, if you just put in that dot phrase and ask those questions, it can help you get a better sense of if they sound more like they have IH or narcolepsy. How do you diagnose it? You do a sleep study, but it's followed by a multiple sleep latency test where we're looking to see how quickly does somebody fall asleep if they're challenged to nap 5 times in a row, 20-minute nap separated by about 2 hours. And so if we see that somebody falls asleep in 8 minutes or less, that is suggestive of pathologic hypersomnolence. If we see that they go into REM sleep within, like during those naps, within 15 minutes of sleep onset, at least 2 times, and that's how we would diagnose somebody with narcolepsy. Those tests are kind of finicky, and you have to have patients off of certain medications like antidepressants, stimulants, controlled substances can all affect the results of those. So it's kind of a finicky test. So that would be one that you could order on your own, or if you wanted to wait and have them be seen by somebody in the sleep clinic, I think that could make sense too. And then I won't necessarily go through all of these. I think just knowing though that the wakefulness promoting agents like modafinil and armodafinil, I think should be used more than they are. They really help people feel more awake and alert during the day. And a lot of patients with neurologic conditions really struggle with that. Biggest side effects that I warn patients about is they can decrease the efficacy of hormonal birth control. And I have already had a patient who got pregnant on this medication even after we talked about that, and that's a real risk. So it definitely can happen. And headaches can be a big issue. We have some newer wakefulness promoting agents that I don't necessarily think you guys need to worry about that we use in the sleep clinic to help our patients with narcolepsy and cataplexy. But these are all things to make people feel more awake during the day. But there's also medication that's given at night to help people get more quality sleep. Like I said, patients with narcolepsy have very disrupted sleep with very abnormal sleep architecture. And these medications can actually normalize their sleep architecture and make them feel markedly better. So we use a lot of these in the sleep clinic, but it's probably not something that you're going to be using as a neurologist, just practicing general neurology or within a different subspecialty. And then this is just the honorable mention for anyone taking their boards. Klein-Levin syndrome is the recurrent hypersomnia where people can have discrete episodes of hypersomnia with completely normal periods in between. These are normally seen in kids, like adolescents, males more than females. And so if you ever have a kid or like a teenager who's having recurrent bouts of excessive sleepiness lasting days to weeks, and whenever they're having those episodes, they have like hypersexuality, hyperphagia, it's probably Klein-Levin syndrome. And it might be on your boards because it's super rare and weird, and they love to ask about that. Okay, that's it. I think we're not too far over, but yeah. Any questions? No. Oh, you can always reach out to us, anyone in the sleep like thing I say to everybody is I think that sleep is the dermatology of neurology. It's a great lifestyle. People ask you for tips all the time on how to do it or how to manage it. But it's a great field. It's very interesting. We have a huge impact